We're going to get started as people are still filtering in, but my name is Brittany Baer. I'm the marketing director at Luminopia. I hope everyone is having a wonderful AAPOS meeting so far. Thank you so much to this packed room for joining us for our promotional symposium today, titled, What is Everyone Smiling About? And there are a few disclaimers. This program is sponsored by Luminopia. Our panelists will be sharing a lot of their clinical experience with Luminopia, so their opinions are their own, and individual results may vary from what they are presenting today. And since Luminopia is FDA approved in the United States only at this time, the content within the presentation is intended for US healthcare professionals. So we have a full hour of content planned for everyone. Dr. Binenbaum will review the clinical trial data for Luminopia, and then each of our panelists will share one patient case using Luminopia in their practice. I'm most looking forward to the panelist discussion, which will be the second half of this presentation, where they'll share tips and tricks and best practices on how they've incorporated Luminopia into their own practice. Scott will share a few updates, and hopefully we'll have time for any audience Q&A, but if we don't have time for your question, please definitely stop by our booth. We have a whole team available to help demo the headset and answer any questions, and we'd love to continue the conversation. So with that, I will turn it over to Dr. Binenbaum, and thanks for joining us.
Hi, good afternoon or good noon. All right, so I think everyone here is familiar with the limitations of patching, which range from poor adherence to still having residual amblyopia even after patching for a long period of time. There's probably a variable amount of knowledge here about Luminopia. So Luminopia, in my sort of clinician simpletons approach, uses a VR headset, but I stress to parents that it's not actually virtual reality. It's just using the headset so that it could present different information to each eye. And the idea here is really as an alternative to patching and drops. So what kids do is they put this on, and they get to select from a very large library of curated content, which is coming from familiar providers like PBS and NIC, et cetera. And an advantage of this is that because they're wearing a headset, that this is presented in a sort of distraction-free environment. So they're completely focused on the content and not what's else is going around. One thing to note is that the headset over time has sort of been updated, and it's really quite lightweight. This may be brought up in the Q&A, but I haven't really heard that the headset size or weight is really an issue, even with younger kids. And the standard dosing that was used in the trials, and which I think most people are using, is to use it for 1 hour a day, 6 days a week. But we can talk about that in the panel. So you heard a little bit about this in talks yesterday, but basically what's going on is there's two basic mechanisms in the approach here. So the first is for the non-amblyopic eye to reduce the contrast in the image or the cartoon that they're watching. And if you lower it enough, it essentially turns off the suppression that's going on, and so the amblyopic eye starts to be used as well. Then the sort of second piece to this is to do masking, or in other words, drop out pieces of the picture from each eye, but in a complementary fashion, so that in order to see the whole picture, you really have to be using each eye. And these are cycled through every, is it 10 seconds, I think? 30 seconds. Every 30 seconds? So every 30 seconds, they change the mask. So it's not always the same. It's these sort of masked out parts or dropped out parts keep changing. And the road that sort of led to this being approved by the FDA included a number of trials. So there were first two sort of pretty large pilot studies that were done at 10 sites in the US And this is an open label studies. The patients ranged in age from age 4 to 12, so it included some older kids as well. And it was a total of 80 patients. And based on the success of those studies, a pivotal trial, a phase 3 randomized controlled trial was done. And I'll talk a little bit about the detail of that. So these were patients aged focused down to 4 to 7, as opposed to up to 12. And to be included, the amblyopic eye visual acuity had to be at least 20/40 and at worst 2200. And there had to be, for the lower ends, there had to be at least and in general, there had to be at least a 3-line or more interocular difference to the non-amblyopic eye. I think the original goal was 120 patients, but there was a pre-planned interim analysis, and the study outcome was met early. So the study was able to be stopped early because regardless of what happened after that point, it was going to be a positive result. So the study was stopped a little early because it met the endpoint quickly. So here's just a little more detail about that. The primary endpoint was at 12 weeks, so just 3 months. It's important to remember that when you're thinking about the effect size here. I already mentioned that the amblyopic eye was from 20/40 to 2200. And importantly, they were allowed to have up to a year of prior treatment. And it turns out that most of them did. About 85% had had prior treatment for amblyopia, in addition to glasses. I guess one last point there is, oops, I don't know if I can go back, but this was designed in discussion or collaboration with the FDA, and it was agreed basically that the appropriate study outcome was a comparison for a superiority outcome of Luminopia against glasses alone. And that was based off of prior amblyopia studies that looked at patching versus glasses alone, for example. So here are the primary results. So you can see over the 12 weeks, there was an increase in vision in the amblyoptic eye that ended up at 1.8 lines. And this was significantly different from the placebo control arm. And the same effect, let's see if I can get it to go there, was seen whether they had been previously treated or not. So again, 84% of the kids had been treated, many for many months, and some all the way up to a year. There weren't any serious adverse events. The most common adverse event reported was headache, which was more common in the Luminopia group than the control group, but they were all graded as mild or transient, did not result in stopping the device. And since then, sort of redesign of the device and making it more lightweight, we think has helped with that. And overall, the rates of ocular adverse events were actually similar between the groups when you look at all the different reports. When they asked parents whether they like the device or not, 94% said that they preferred Luminopia over the patching in general and over the patching they had done previously. And one advantage of this device is that you can track compliance precisely. So it was known that there was about 85% compliance, which is probably more than double what we might expect even in a clinical trial from patching. This is the official FDA indications that have been approved. So it's for amblyopia. I'm just going to say them. So this is for amblyopia that's from anisometropia or strabismus. And it's for patients 4 to 7 years of age. You use it over the glasses, so they wear the device over their normal glasses. The device does, sometimes this question comes up, the picture that they're seeing is presented as if it's at distance. So they don't need to accommodate for this, but they do wear their glasses. And the indication is obviously to improve acuity, and it can be used both as first or second line treatment. The recommended dose is 1 hour per day, 6 days a week, but the actual duration and dosing is up to the provider, and that's us. It's actually very easy to prescribe this. You can do it in your electronic health record. We have Epic at CHOP, and it takes me about 40 seconds to do this. Everything's right. It's all just a preset order. I just fill in whether it's right eye or left eye and click another couple things, and it goes off to an electronic pharmacy called PhilRx, who then takes over and handles everything. And we could talk about that in a little more detail in the discussion as well. If you don't have an EHR or you don't want to set it up in there, then you can also fill out an enrollment form and fax that or phone it into the online pharmacy, the virtual pharmacy. But really, it's very simple and quick and easy to prescribe this from the doctor's point of view. So that's just a little background about Luminopia and the studies that brought it to FDA approval. I guess I kind of skipped saying it was FDA approved after the positive results from the pivotal trial. And so we're just going to each present just an example case and then have a discussion and take your questions. So my case will be first since I'm already standing up here. And so this is a 5-year-old girl who had moderate amblyopia. She had a accommodative VT, which was well controlled in her glasses. She was +3.25 and +4. She had not had prior amblyopia treatment. And I discussed options of patching, drops, or Luminopia with them. And they decided they wanted to try Luminopia. And so I prescribed it in an hour per day, 6 days a week. And when you say the prescription, the only real important detail you give is which eye is the amblyopic eye, because that obviously changes the way that the reduced contrast and the masking is done. And so this is what transpired in follow-up. So she started off at 20/50 in the amblyoptic left eye and 20/25 in the right. The vision basically stayed about the same in the right, although improved a little bit at the end there. At 3 months, the amblyopic eye had improved from 20/50 to 20/40 +2. There was a little bit of a gap. Oh, I should just orient you. So the graph on the bottom for all of our cases is the report that you can see their compliance on. And the y-axis is basically telling you how many of the minutes of the target 60 minutes they actually did. So you can see that that's what this red line is here. And so most of the time they did what they were supposed to do. Here they must have had a few extra interesting cartoons they identified, so they did much more than 60 minutes. Same thing here. I don't know what that was that they really wanted to watch for an extra hour. Then what happened was they were supposed to come back here around 6 months or so, but I think that there was I forget if it was COVID or the flu, but they got sick. And so they kind of stopped for a little bit, and they also missed their appointment, and they came back at 9 months. At that point, the acuity was now down to 20/30 in the amblyopic eye. They continued to do it a little bit longer, and at 10 months, they sort of self-stopped. I don't know exactly why, but they stopped at that point, and then they came in for their 12-month visit, and the vision had gotten to 20/25. So there was still a 1-line difference there, but we had started with a 3-line difference right on the left, and we could see that the acuity went from 20/50 down to 20/25 over that 12-month period. So Courtney's going to give the next example case.
Thank you.
Yep.
You just advance on the click.
Or the green button.
Okay. All right, so I'm going to present a 5-year-old girl who has some anisometropic amblyopia. So she came into my practice already diagnosed with anisometropic amblyopia. She was seen somewhere else at the age of 3, given glasses, and had just kind of been wearing glasses for the last year. When I first met her at the age of 4, she was 20/50 HOTV matching and 20/20 in the left eye. You can see, and I think one of the reasons I wanted to highlight this case is she had a pretty remarkable degree of anisometropia, specifically anisocylinder. So I thought that was an interesting kind of fact about her. She had a history of craniosynostosis, and for the most part was ortho and primary, but she did have a Y pattern XT going up to about 20 diopters, but it was only an up gaze. I did have preliminary stereo. She had about 4 9 circles, and it's kind of standard My first line, usually in this age range, she was only 4 years old. And something we haven't talked about yet is the pupillary distance is important in prescribing this headset. They have to be big enough to actually qualify to get Luminopia. So she got 2 hours a day of prescribed patching. When she came back, she hadn't improved at all. So I increased my patching to a target of 4 hours a day. This family was really committed, and they actually did execute 4 hours a day of patching, and she came back. Really no improvement. I think at that point she was doing some Snellen acuity, so you had that kind of corresponding mild, what looks like decrease in vision. So I recommended Luminopia, and the parents were actually really excited about this. I think it took a little bit to kind of get in the groove, and you can see kind of around that 1 month, there was probably a spring break that I think coincided with that, and then they kind of got back in the groove, and just like we talked about, there's some days where they actually went above and beyond and did more than the prescribed 60 minutes of patching, and then we had a little bit of a hiccup, which I'll probably talk about in the discussion section, just at the time of the renewal of that month too. But then they really committed, and she went from 20/60 at starting to 2-line improvement to 20/40. And I think the cool thing about her is she actually went to 6 out of 9 circles the next time I saw her, so she did get some improvement in stereo. All right, Dr. Warner.
Hi, so I'm going to share with you a case of more severe amblyopia. My patient is 4 years old. I diagnosed him with accommodative esotropia at 2. It was late in his second year, almost 3 years old, and he had had an eye turn for 6 to 8 months prior to me seeing him. With hyperopic prescription, he was ortho in his glasses, but his vision was still really poor. We attempted patching, but for various reasons, patient cooperation, parents not dedicated to patching, it was a complete failure. Then we attempted atropine drops as well, and despite rigorous conversations in the office and the box clearly displaying which eye it should be put in, sometimes the parents would put it in the amblyopic eye, which was not helpful. Despite all of the poor initial therapy, he did improve from 2250 down to 2200 in his amblyopic eye. And then he kind of plateaued for like 6 to 8 months and nothing was improving. So at this point we discussed Luminopia, and I did prescribe it for 1 hour a day, 6 days a week. And this, I think, is impressive because it was the first treatment that he actually tolerated, and he didn't put up a fight about it because he could watch Nickelodeon for an hour every day. And so after 3 months of therapy, he broke through his plateau of 2200, and now he's down to 2150. And his stronger eye, non-amblyopic eye, has remained the same throughout the entire course of treatment.
All right, great. So those are just some sample cases, and we can talk a little bit more generally about what we're doing with Luminopia, and then take your questions. And just to re-stress a point, this discussion, we're going to talk about our opinions. So none of this has been scripted. We haven't really told them what we think or what we do. So we're trying to just say what our opinion is, and conversely, I think some of us use this off-label from that description that we said. So if that's germane, we'll mention that too. We'll highlight if something's off-label, since this is a corporate-sponsored symposium. But really, we're telling you our opinions as opposed to Luminopia's opinions. So first question, we'll have a few questions to just prompt the discussion. So it's like, what types of patients do you consider for Luminopia? And you can consider sort of different variables, naive, treatment-naive patients versus, they've already been treated, strabismus patients, if they're post-surgery, or what size of strabismus, the severity of the amblyopia. We saw quite a variety there in those cases. What ages are you considering, et cetera? So maybe, yeah.
All right, so I'll kick off. So I think pertinent to mention, of course, that a lot of probably the prescribing I'm doing is a slight deviation from the strict FDA approval kind of guidelines. I have a practice that really does have a lot of patients that have had or undergone cataract surgery or have had or undergone glaucoma surgery, and as a result, there's a little bit of a mixed mechanism to their amblyopia. I have a lot of patients that have, for that reason, patched from a very, very, very young age, and we've hit a ceiling. So to me, I have loved rolling out Luminopia in my practice because I think these are really, really motivated parents who feel like they have put in so many patch hours and have gone through really tough surgeries, and then you present them with this sort of new, cool idea, and they are just 100% on board. And there have been times where I've really seen stagnation, and this has been something that has really moved patients forward in their visual acuity.
Yeah, I would agree. I offer this to treatment-naive patients, but most of my patients have already been patching or using atropine. And it's frustrating for the parents, it's frustrating for the kids. And once you introduce this, I have not had, every time I talk about this, the kid in the chair is like super excited, giving mom a thumbs up. And mom's like, I don't know if this is going to work, but we can try it. And compliance has been so much better, and it's a much easier discussion to have with families.
Is this still on? Okay, good. What about strabismus? So is there some magnitude of strabismus you'll think about before prescribing, and or if it's large, do you fix the strabismus first?
I think it's, personally, I think it's best to fix the strabismus first because theoretically it should work with a small angle strab or no strab. But I've also prescribed it in kids where I think the largest is probably a 30 ET. And I don't think it's a binocular function at that point. Maybe it's glorified patching, as someone said yesterday, but it works and they're still using it. And so as long as they're using something to help improve their vision, I don't see a downside to it.
I think I'd probably stick to smaller angles more within sort of our guidelines, but I definitely have employed it post-surgical when I've gotten small undercorrections or small overcorrections. A lot of times I have seen that those angles have actually changed and gotten better when there's been sort of a small difference in vision too.
Great. Yeah, so I do kind of the same as what you guys, I haven't prescribed it for larger angle strabismus. I mostly stuck to small angle, thinking that I do want this binocular mechanism to work so that they could be within some small degree. They could use their eyes together. And I do offer it for treatment naive and people who've been treated for a long time, whether it was a while ago or it was recently. And actually, I will use patching for larger angle strabismus, so I'll do that a little bit, then do the strabismus surgery, and then start Luminopia right after. I've done that a couple times already. All right, so next sort of prompt here is, well, how do you discuss this with your families?
When we talk about Luminopia, I explain that it's theoretically a different mechanism that's helping improve their vision. That it's only a limited amount of time compared to, like, say, patching. So I prescribe it for 1 hour a day, 6 days a week. I do tell them if your kid's going to be on a screen and you want to give them extra screen time, please use Luminopia, not a regular tablet, because then they're actually working on their eyes at the same time. And because it's projected at distance, we don't have to worry about becoming more myopic. And kids are on screens all the time anyways. So I feel like it's just a better alternative to a traditional tablet.
Yeah, a lot of times I'll direct the parents to, we have a lot of the pamphlets in our office and there's a QRS code on there, and they can just take a photo, with their phone. It pulls up the Luminopia video. So I think that actually does the best sort of descriptor instead of me trying to explain what dichoptic masking is and go into the nuance of binocular, suppression and et cetera. I just kind of show them the video. I say, this is a new technology. It works in a way a little different than patching. And, your child has patched before, they haven't patched before, but I think it's really cool. And then a lot of times I really target, especially for that like 6 and up crowd, a lot of my discussion to the child. And I really hype them up because, it's a VR headset and it's something their siblings won't have, and it's gonna make them more special. And I think that actually goes a long way towards getting the kid excited. And if the kid's excited about amblyopia treatment, 9 times out of 10, the parents are like, okay, sure.
Yeah.
I'll add that around the holidays, a lot of kids wanted a VR headset for Christmas. And so in November and December, there was a few moms that were like, we need to get this for Christmas for them. I was like, okay.
But I do tell them that it doesn't stream or do anything else that a VR headset does.
Right.
Because then they'll be disappointed.
Yeah. So I haven't really used the video much, but like I have my own little spiel, which is basically that, like I said before, it's a VR headset, although it's not really VR. And then I just explained to the parents that it makes them use both eyes together instead of just one, the way patching does. And I give us, if they're interested, I give them a little explanation actually about the suppression and the contrast and the masking. Some parents are interested in that detail. That's kind of basically it. I explained that, I think that we're going to talk about the prescribing in a second, so I'll hold that comment. But how do you set expectations with the parents related to actually getting the device and what the cost might be?
So this is one of the things, this can cost, depending on your insurer, anywhere from $49 to about $150 per month. So I'm very upfront with that because I don't want a cost surprise to kind of mislead a parent and have them kind of feel like they were led to believe this would be just as simple and straightforward maybe as patching. But I do always tell them that, this is a treatment we're trying. I want you back within, 3 months, because if it is not working, I don't want you continuing to pay this out-of-pocket cost. And I think it's a motivated population that will, if it's something that they want, then they usually are comfortable with it.
Mm.
And I've been surprised at the amount of people willing to go forth with this because, you think of a Medicaid population, which is predominantly what I see, and they're on limited income, but it's something that they still are willing to pay for to help their kids see better.
Yeah, I've had a similar experience. Cost hasn't been really a factor, and I think I explained to them that we're going to I send the prescription to the pharmacy, and then the pharmacy talks to their insurance company, which is what happens, and figures out what the cost might be. If there is a cost, there might not be a cost if it's covered. Even with, I think, a copay, the copay might be less than $50. I think $50 is, so let me back up. Luminopia, I think, has a arrangement where if it's not covered by insurance, they have sort of a program to improve access. So if it would be a Medicaid patient who, and correct me if I'm wrong on this, a Medicaid patient whose insurance won't pay for it, then the cost is $50 a month. And if it's a private insurer, then it's higher. And the highest that goes is, I think, $150 a month. So that's the highest it would cost. I stress to them, and I found that that isn't usually that much of an issue. And I think about 75% of families follow through with the prescription, at least, I think, from the Luminopia data. One thing I do stress to them is that they don't have to buy this thing, that they get it, they use it, then when they're done, they put it in the box that the pharmacy sent them, and they send it back, because sometimes they think they have to buy it, and that creates a little confusion. We can answer more questions about all of this in the Q&A. Any pearls about the prescribing process or your experience with it? Any issues?
Well, I have to say, I think it was the prescribing that held me back from starting to use Luminopia. I just assumed it was going to be challenging to prescribe it. And as you alluded to, it's actually quite simple. I have Epic as well. I have all smart phrases to enter in all of the necessary data. You just specify the eye that you're treating and then send it to PhilRx. I made the mistake of not putting in refills on the first probable 10 to 15 patients I prescribed it on. So then I was getting monthly calls from PhilRx, but the people are lovely on the phone and they actually answer quite quickly. But I will say, do put in a refill because that was a mistake. And then I would also say, tell your parents that they're going to be getting a text message, and it doesn't necessarily say in that text message, this is a message about your child's Luminopia. I think it uses verbiage about a prescription, and it can be a little bit vague. So some parents have kind of claimed that they haven't heard from the pharmacy or gotten anyone in touch with them, but then when you review what it should say, they actually did, they just ignored it.
Yeah, I don't have Epic. I had NextGen, and we just switched to ModMed last week. And I think having it in your EMR system linked to the diagnosis code is the best and easiest way to have it sent. All you really need is the diagnosis code, and that's how they program the VR headset. Aside from that, I think it's been really straightforward. They send you an email or a fax every week. PhilRx does, of all the patients that are currently on therapy. And so you can follow up if there's any issues with a patient not responding to text messages. I think after they get the text message, they get an email if they don't respond. And so PhilRx has been great about reaching out to patients. And as soon as it leaves my office, I don't have to take care of anything. And within a week, they get the headset. And some patients have had that text message as they're walking out the door that same day of the appointment. It's pretty quick.
Yeah, my experience has been the same. And I've heard actually really good feedback from parents about PhilRx, which is not part of Luminopia. It's just the online pharmacy that handles the prescriptions. And they're like really responsive if there's any questions or problems. So at least in my experience, the parents have had a good,
I had a good experience calling them as well. So I would actually say it's been surprisingly streamlined.
Yeah. I do put down like 11 refills, or the max I can do, so I don't run into that
now
problem.
I do.
Yeah. I also put in the comments field, I put down if they've patched or used drops before, just because I don't know if that comment might help with insurance coverage at some point, to say like, maxed on this or failed this before.
Yeah, you do want to put down, so you're prescribing it based on eye, so you'll write, Luminopia left eye, Luminopia right eye, and then, in the comments field, you want your ICD-10 code, and then, again, your prescribing number of hours a day and things like that.
Yeah, one just other little pearl related to that is that you're saying what the amblyopic eye is, unlike with atropine where you're putting it in the other eye.
Yes.
You specify the weaker eye, and then it does what it needs to do. All right. How do you guys approach follow-up? Like, when do you see them back? How often are you following them? And have you used the adherence portal that you can as a physician?
So I see kids back every 3 months, just like I would with patching. I do use the adherence portal, not on every patient, but particularly if they're not improving and it looks like, why are we using the device? I sign on there, and if they have less than 50% compliance, then we have a discussion about that. I sometimes think parents overestimate how much they're patching or how many times they're putting the drop in or how much the kids are using the headset. And so it's a good way to kind of keep them accountable, essentially. And some parents have kind of got the deer in headlights look like, oh, you actually know what we're doing. And then I think they're better next time.
I actually pull up the adherence portal sometimes with mostly older kids, because I think they think it's cool that I can somehow know exactly what they were doing. And sometimes I'll point out a day and I'll be like, what'd you do this week? You didn't use it much. And it becomes, I think, a lot more interactive in a way that kind of harkens back to if anyone brought in like patch calendars or things like that with their amblyopes. I just really feel like when you get the child to kind of engage with adherence, they start to be like, oh, Dr. Kraus is watching me. And it really makes them have a little bit more fun with it.
Okay, great. And any other general feedback you've heard from the kids or the parents?
I told someone once that there was Bluey on there, and there is no Bluey. So do not make that mistake. There's Blue's Clues, but no Bluey. But I would say across the board, it's either a hit or it's not. I think if it doesn't work, you know quickly, like the child just doesn't ever put it on, and the parent tells you, and you just close that door, because it's just they're too old, the amblyopia is just not treating. But the kids that do it, they really like it, and they really like that it's something new and different. So I hear a lot of positive feedback.
I also hear a lot of positives. I think the biggest negative is that YouTube's not on there and Disney Plus isn't on there. So, I mean, that might be something for the future, but right now that everyone else has been pretty happy with it.
Yeah. The other thing we do talk about is that it is Wi-Fi enabled, and it is a bit challenging to change the Wi-Fi that it's hooked up to. So most parents use it at home and they hook it up to their home Wi-Fi, but I think sometimes you might want to be going to Starbucks and hook up to the Starbucks Wi-Fi. And it is a little bit cumbersome to do that. So it's just something that parents will tell me.
Okay, great. And just a fun question. So what's one thing you wish you had known about it, Luminopia, before you prescribed it to your very first patient?
I think you know mine. Refills and no Bluey.
Okay.
I think I wish I would have known how easy it was to prescribe. I mean, was really surprised when we first started it. I didn't think it was going to be so streamlined, and it really was.
I agree with that.
Yeah. When I saw this slide question, the first thing that popped into my head, which is the truth, I hope I can say this, is I was surprised that it really worked. So, I was surprised at how well it worked. It's definitely worked very well in more patients than it hasn't, So anyway, I'm going to turn it over to Scott, who's going to do some company updates and then the Q&A.
First off, I wanted to thank all of our panelists, Dr. Binenbaum, Dr. Kraus, Dr. Warner, for spending this time with us and sharing your perspectives on the technology. Wanted to thank AAPOS for another great year, another amazing event. Hard to believe this is my 8th AAPOS, so it's been most of my adult life that I've been coming to these conferences, and it's just getting better and better every year. Wanted to thank our team as well. You may see our team scattered around the room. They're here to be helpful and to answer questions afterwards. So I wanted to thank the team for a lot of incredible work that's happened over the last year for us to be able to bring this technology to more and more patients and families. So for those that I haven't had a chance to meet, so I'm Scott Xiao, co-founder and CEO of Luminopia. Started the company about 8 years ago out of my dorm room at Harvard, actually. So I was doing a neurobiology degree and got interested in creating a more engaging and a more effective treatment for amblyopia because I had a good friend of mine who wouldn't patch as a kid and told me about his experience with patching. And me and a classmate of mine quickly realized that there was a need here and there was an opportunity to use technology to create a more engaging and a more effective treatment. We didn't realize how long it would take. Our early timelines were much more optimistic, but it's taken us about 7 or 8 years to get to this point. And it feels really surreal to be here today where we are. We started commercializing just over a year ago after our FDA approval. Over the last year, we've grown significantly. We've seen rapid uptake from physicians and patients and families across the country. So I'm proud to share that we're now up to more than 500 physicians across the country that have written a prescription for Luminopia, and more than 3,000 patients that have actually received a prescription for the product. The reason that it's been a long journey to get to this point, one of the main reasons is we've always been committed to being a science-first company. From the very beginning, we took the approach of treating this like a new pharmaceutical. So multiple pilot studies as well as a nationwide randomized controlled trial, as Dr. Binenbaum alluded to, which led to the initial FDA approval, but also not stopping there. So as we look ahead, we are sponsoring the Pupil Registry, which is a look at real-world outcomes with Luminopia. The very first analysis of that was presented by Dr. Yuna Ku at the scientific session yesterday morning. We've got 179 patients currently enrolled in that registry with a mean age of about 8.5 years. As the panelists have alluded to, we have seen off-label prescriptions, so that's the mean age that we've seen, and more than 80% of those patients that have been through patching and or atropine. Across the entire population, so across the very broad population that we see, we've seen a mean improvement of just over a line at week 12. And importantly, we looked at a subgroup of patients that matched the eligibility criteria of our pivotal trial. We wanted to understand how is this technology working in the real world compared to what we saw in our trial. We're seeing in that subgroup an average improvement of 1.7 lines and compliance of about 83%. Both of those numbers very comparable to what we saw in our pivotal trial. Looking ahead, we're continuing to run randomized controlled trials as well. So we're excited to be partnering with PDIG on 2 randomized controlled trials that are in the works, ATS 23 and ATS 24. For those of you that are PDIG sites that are intending to participate in the studies, we would still encourage you, if you're interested in bringing Luminopia to your patients, to reach out to us and learn about the prescribing process. We know that the eligibility criteria for the trial isn't going to encompass all patients, so there's still an opportunity for patients that don't qualify for those studies to get Luminopia today. And lastly, I wanted to touch on what we're working on beyond generating more and more evidence. So our top priority this year is payer coverage. We do see some payer coverage already, but it's still early, and we're working hard to secure more and more coverage. We're working with national and regional plans as well as with key Medicaid plans to advocate for the technology. The patient access program that we have in place, when it's not covered, will remain in place to ensure that all patients have the ability to access Luminopia. And this is where we could use your help as well if you do work with a regional or a national health plan to be able to advocate for the importance of amblyopia treatment more broadly, whether it's Luminopia or not, because we know that there is an awareness and an education problem among health plans. They're not familiar with this condition. They're not familiar with why it's important. And then lastly, we've got multiple product releases that are in the works to further enhance our patient experience. There's some discussion around content, and we certainly have heard feedback that more content is better, so we're hard at work at that, and we're constantly refreshing the library, bringing in new content that the patients can watch. And then lastly, this is a little bit more in the future, but we are working on a parent companion application to the product, which will give parents the ability to follow along with treatment, give them more visibility into what their child's watching, allow them to curate content. We can nudge them if the parent or the child hasn't been using Luminopia for a period of time. So we're working on that as well. So with that, that concludes the programming that we have planned. There's a QR code on the slide here, which you can scan if you're interested in bringing Luminopia to your practice. We've got a team of key account managers in the back who cover most, if not all, of the country now. So we're happy to come by and give your team and your staff a demo and to introduce the technology to all of you.